John Mattison, who's the Chief Medical Information Officer at Kaiser, has called himself an accidental informaticist because he was quite happy being a fourth-generation California doctor. But then when he implemented an electronic record in his family practice, he was drafted into an effort to create enterprise electronic medical records at Kaiser. And so that's taken him, it seems like the first step in a very long journey of doing an enormous amount with medical information at Kaiser. He oversees all of the information systems deployment in the Southern California region of Kaiser, which includes 140 clinics, 13 hospitals. He chairs Kaiser's National IT Infrastructure Governance Group, and he's led the KP Health Connect project in Southern California, which has been fully implemented in every clinic and hospital and represents the single largest deployment of a completely integrated electronic health record. So perfect person to have be part of this discussion. Tim?
Can I throw in one more thing?
Yes, please.
About John? I know Todd Park made a comment that he said if the rest of American healthcare worked like Kaiser, we would have solved the problem.
Well done, well done. Yeah. And Tim, who's jumped in before he's been introduced in typical O'Reilly fashion, many of you know, is the CEO and founder of O'Reilly Media. They published an enormous number of books, which many of you have probably grown up on, and host a lot of conferences. He and I worked together on the Web 2 conference as sort of the father of the term Web 2.0, and then also dear to my heart, the father of this idea of Gov 2.0 and government as a platform. Currently thinking a lot still about government, but about data, and a lot of effort going into his Strata conference and now Strata RX, which will deal with health information. He's been very influential at the White House in terms of their strategy, both around government data and particularly health data with Todd Park, who's of course now our federal CIO. He's also a venture capitalist at O'Reilly Alpha Tech Ventures. So obviously we have the two perfect people here to talk about this subject. As you saw, the title of the talk is that software is eating the healthcare world. But I think what we're really here to talk about is that we know that this market is being disrupted. You guys are doing it. It's not an if, it's a how. And I think what we're getting at is what are the ways that this disruption can really fix what's wrong with this system and create something dramatically better for both patients and the industry and doctors. And as sort of we talked about in our prep, what are the ways that this could really go wrong? There's a dark side to this too, and I want to put that as sort of the frame before we get started. We're really going to draw out some of the utopian visions and some of the dystopic visions. So I wanted to start, Tim, with you because you wrote a paper about 2 weeks ago along with your staff called The Wanamaker Problem for Healthcare. And you've laid out some of the ways in which information can really disrupt this market in a very positive way. Can you talk a little bit about what you said in the paper?
Sure. So first off, I should qualify my comments by saying I have very little experience in healthcare. I have a fair amount of experience as a technology Pied Piper, kind of saying, hey, over here, over here. And that's kind of the role that I'm trying to play in healthcare today, trying to bring people from the consumer internet and other areas like that over into an area where there's a huge need for their skills. And so my thinking about data has really evolved on the consumer internet. And what I've watched is this incredible development of a set of technologies and also a set of practices about closing the loop with data, and this is most famously, done by Google. I think they're the most successful at it, and because of that, I framed a lot of what the opportunity is in healthcare around the famous saying of department store magnate John Wanamaker, who back in the 20s, maybe even a little earlier than that, said, I know that half of my advertising does not work. I just don't know which half. And Google really took a huge step towards solving that problem. The old model was, well, you just put out a lot of advertising and somewhere out there, some of it works. But the pay per click model and Google's incredible focus on data and outcomes and being able to predict the outcomes and show the ads that would be more likely to work really transformed the advertising business and led to this explosion of data-driven approaches to the consumer internet. And so, you know, I look at that and I say, that technology and that knowledge and that mindset is exactly what we also need in healthcare. And we're at the point where if only we can heed Andy's call to free the data, where we can start to use massive computational power to crunch on evidence, to get you know, closer and closer to that, solving that N of 1 problem that Jordan mentioned, and really get data that helps us to deliver better care. We can close the loop, we can reduce costs. And so I'm out there looking for people who are doing that, who are applying the techniques of data to healthcare. And you know, as Jen mentioned, we launched a conference called Strata RX to focus specifically on data in healthcare. But you know, I'm sitting here going, well, you know, right next to me is somebody who actually knows what he's talking about. So. About that very subject. So,
John, you took a read around Tim's paper, and you're, as he says, you're the one really putting into play in this context. What did Tim and his team get right?
If you haven't read Tim's paper, I highly recommend it. He got just about everything right. It's a brilliant illustration of how the innovation of today, and particularly around big data, is going to make a big difference. So. Let me roll the clock back about 20 years when I wrote my first business case for why we ultimately spent many billions of dollars to implement an electronic health record, and it's highlighted very clearly in Tim's paper. And that is, without the data, you don't know what you're doing. So the business case that I wrote was a single page. It was a PowerPoint slide, and it showed the quality improvement cycle of measure what you do, model what would happen if you changed it, implement that change, and see what the result is. My entire business case was focused, contrary to every other business case, that, oh, we're going to produce redundant lab tests and we're going to have better coordination of care and yada yada. The real business case for why we were justified in spending billions of dollars was to shorten the cycle time for discovery and invention and innovation and implementation, and it's what I call the compression of transformational time. And we have already begun to realize that compression of transformational time by being able to look at what's actually happening and know which 50% of what we're doing works and which 50% does not. And I want to refer back to the N of 1 again, because what is happening in the big data world, particularly with the infusion of genomics, and make no mistake, we've been waiting a long time for genomics, but genomics is going to be very real for every one of us in this room very, very soon as the cost plummets to do your full genomic sequence. And when that happens, unless you have an identical twin, you are truly an N of 1. And so the ability to understand which drug, which intervention, which prescription, which approach, which care plan is best for you is going to be available only to the extent that we can identify people who are very similar to you amongst a huge cohort. And the larger the cohort, the more we can personalize that information. The other point I want to make is, while data is table stakes for everything we do going forward, it's not the differentiator. The differentiator will become more transparent around performance and trust. And I really want to highlight the element of trust, because in healthcare, if you don't trust the source of your healthcare, all the data and all the numbers are meaningless. And so we may come back to that later in the discussion. But data is key to advancing the science and compressing the transformational time. But ultimately, what's done with that data is what develops the trust.
John, Tim had an example in his paper, I think it was about tamoxifen, the idea that you know, we have been told for many years it's, I think it was something 80% effective. It's not. Right. It's 100% effective in some people and 0% effective in others. And that's a big difference. And it makes a big difference to the care. How is that playing out at Kaiser? Are we at the point, if you're a Kaiser patient, that you'll know if you're one of the 80% or not?
Increasingly, we are able to identify, and the example that Tim gave is the Herceptin receptors in breast cancer and the ability to know which therapy is customized. Cancer is fundamentally a genomic disease, and so you can't go to an advanced cancer treatment center today without having your tumor genotype repeatedly, because it changes over time, and your therapy must change as your cancer mutates. So we're doing it to the extent that we can today. the full pharmacogenomics equation relies on having both a large data set as well as having the genomic signature of every individual. So the University of Wisconsin has just announced a chip that they're releasing that tells you which antidepressant, which statin, which anti-seizure medication is best for you based upon your genomic signature and the metabolism that you have for those individual drugs. So we're on the cusp of a huge revolution. The one thing I'd like to say that triggered some of my thoughts in Tim's paper is, where do the drug companies fall in this? What does it mean when 80% of the patients it's 100% effective and 20% it's not effective at all? I've done some consulting for pharma, and I was back in the East Coast about 2 years ago, and I suggested an entirely different business model that is the inverse of the current pharma business model, and that is that in this informed world, in this world of informed care, when we do know who it works for and who it doesn't work for, oh, and by the way, we know who's going to have bad side effects or not based upon the genomics and the pharmacogenomics. The first drug company that figures out that either they're going to be has parallels in the music industry and iTunes. The first drug company that figures out that their market is to make sure that everyone who can benefit by their drug safely takes it, and nobody else who doesn't benefit by it or who is at high risk of a side effect takes it, so that they look for both of those and apply decision support and support methods in healthcare delivery that support getting the drug when it's needed, but only when it's needed, is going to inspire a level of trust that's going to catapult that drug company. So today,
that's great insight.
Today they're one of the least trusted elements of healthcare, and the first one that gets to that trough is going to be the most trusted pharma and set the standard for the rest of the industry based on that observation that Tim highlighted.
That's really great. I think this is getting to a topic that started already earlier this morning, and I'm sure will continue throughout this, which is the alignment of incentives. And you have a certain model with Kaiser. Really what this, I believe this group is the ecosystem. It's a lot of small pieces loosely joined, and the trick of alignment is very difficult there. Tim, do you want to talk a little bit about how you see that this utopic vision working out in a way that all of the small pieces are aligned towards great patient care?
Yeah, boy, it's such a tough thing. You know, I guess the way I think about the internet and healthcare is there are a number of lessons. And the first one is that a really robust ecosystem depends upon standards. And so I think, you know, one of the things we're doing right is we're starting to move in the right direction towards you know, coming up with sort of minimal mechanisms and standards for health records to move around, for data to move around. But I think we're really a long way away from where we need to be. And particularly for me, one of the big issues is in the area of privacy. You know, as you mentioned, you know, we need large data sets in order to get to this you know, truly personalized medicine, and yet we have a privacy regime that says, oh my gosh, and a lot of scare tactics that say, oh my gosh, you can never anonymize that well enough. And you know, and I think some of that, of course, goes back around to the incentives problem, because one of the reasons why it's such a scary thing to have your health data out is somebody might discriminate against you. You know, so then that kind of leads us around the payment incentives and the like. I mean, you know, I don't think there's anybody who would build the healthcare system that we have today if they were starting over. You know, and it's the thing that's really tough about it is a true free market system might work. A true government-provided single-payer system might work. A hybrid in which there's regulatory capture of the system by all kinds of particular interests, you know, which lock in their particular profit motive, is the worst of all possible worlds. And I don't know how we get out of that. I mean, I do think that, you know, kind of large groups like Kaiser that are kind of both insurer and provider, I think, is a really great model, because your incentives are aligned within your system. You know, whereas in other cases you have a large provider and they're actually using their scale to extract even higher rents out of the insurance system and to get preferred payments of various kinds. So it really is an incentives problem. And I think for the entrepreneurs among you, business model innovation as well as actual technology innovation is probably really, really important.
So, and I completely agree. One of the reasons that I left the fee-for-service world and went to work for Kaiser Permanente as a physician before I became an accidental informaticist was because of the very alignment of incentives. You cannot participate in even the highest level executive discussions in our company without focusing on how do we get the most value for the lowest premium for our members. That's just the incentive model, it's the ethos, and it works. And it's very liberating for physicians to operate within that incentive framework. So it does become a very core aspect. In terms of the privacy issue that Tim mentioned, I just finished a chapter in a book that's going to come out in February about some of the trade-offs that have to be made between sharing of data and the privacy issue. And privacy is not entirely a regulatory construct. It really does reflect a lot of people's concerns about being harmed in some way by a violation of privacy. And one of the things that I included in that chapter, and a challenge that I'm going to give to Andy Groves is, and anyone in this room, is how do we include a full genomic sequence in every single health record, because it's fundamental to understanding your N of 1 and to giving you the best proper care. How do we include that in your health record and avoid the very simple re-identification of who you are based upon your genome? So that's yet another challenge that we have in this privacy space that is looming large as we move into the genomics era, because it won't be reasonable to treat someone. In fact, it'll be considered malpractice in a very short period of time to treat anybody without a full genomic sequence at your disposal, obviously with the consent of that individual. So the other thing I'll mention around standards is that there actually is a standard called the Clinical Document Architecture, and some substandards under that in terms of terminology that can be used to share health records across institutions, across electronic health record vendors, and that is now part of the meaningful use requirements. So physicians and hospitals are being reimbursed by the federal government for adopting health records, and unless their health record is certified to be able to send and receive information that way, they won't receive their meaningful use money. I'm very familiar with that standard because I founded it about 16 years ago. And all of you that are working in the healthcare space, I encourage you to familiarize yourself with the clinical document architecture so that the data representations you have, to the extent you use structured data, can be represented in that fashion. Similar issue is natural language processing and its role for being able to merge free text and structured data so that we can operate on the full set of data, because we will never have a completely structured set of data, so we need to be able to do both. And again, the clinical document architecture allows for that kind of normalization of those two distinct data sets. So there are a lot of promising things that are happening in the field right now to bring the data together. The last thing I'll mention is that there's a couple of different initiatives for how we can do the big data aggregation. So we have 9 million members in Kaiser Permanente, and we can really leverage those data for the benefit of our members internally. But again, in this world of big data and genomic sequencing and the N of 1 phenomenon, there is no such thing as a data set too large. In fact, I did a simple calculation. Those of you familiar with the factorial sequence, it's interesting to note that the number of humans alive is less than 13 factorial, and the number of humans ever alive is 14 factorial, and that's far less than the variation of the human genome. And so to the extent that we don't have an N of 1 for every potential permutation of the genome to compare you to, it becomes somewhat problematic. So how do we address the privacy issues and yet enable large-scale studies that cross institutions? So one method has been promoted by the editor-in-chief of JAME of the Journal of American Medical Informatics Association, called Scanner, which is where you apply a common query across the data where it resides. And you prospectively agree to the query and you agree to the data representations, and you aggregate the results and then export the aggregate so that there's no risk of someone re-identified members of those cohorts. So that's one model. The other model is to have sophisticated methods for de-identification, and two of the former directors of the National Coordinator of Health at the federal level are supporting an initiative sponsored by the Cantor Foundation that's moving forward right now to do that. So there are some initiatives to do that. They're a long ways off from being realized, but they're critical to get at Tim's challenge and Andy Grove's challenge of freeing the data.
I think you said something really interesting there, you know, which is, again, in terms of expanding our headspace of possibility, it's really important. One of the, you know, approaches is, okay, we're somehow going to sanitize the data. And the other is that we're going to actually change the architecture of the system so that the data actually resides, you know, more out at the edges. And that actually sounds very internet-ish, you know?
Right,
and
right.
There's so many problems that on the internet that would be solved by an architecture of decentralization rather than an architecture of centralization. Unfortunately, centralization tends to lead to higher profit margins and the possibility of lock-in, and so there are, again, a lot of economic incentives for people to have an architecture that allows them to aggregate and centralize and gain power over the data, whereas the decentralized model, I think, is probably a better model long-term. Those two things are always they're fighting on the internet every day. You know, a new thing comes out, it's typically decentralized, it leads to a lot of innovation. Somebody figures out how to get more out of the system, and they gradually re-centralize. And so this Hegelian kind of...
That's a great illustration of the interaction of finance and data architectures.
Yeah.
A parallel one I'd like to talk about is policy and data architectures. And so one of the things that's going to be increasingly apparent to every one of us in this room is that how are we going to benefit by having our genome as part of our medical record if we can't compare our genome to similar genomes and similar outcomes? How many people here have done 23andMe, or any of those pathways? Okay, there's like 3. Oh, great. Okay, that's the highest response I've seen in any audience.
This is the crowd.
This is a genetically liberated population. So if you think about how am I going to leverage that information, you really need to expose that information. So we're going to have a very different public dialogue about what it means to expose your genome into the ethers in order to fully benefit by it. And I think that's going to drive policy. Where I think it's going to play out is, unless Andy Groves or someone really, really smart can figure out how to prevent re-identification from something that is inherently identifying more than anything else on the planet as to who we are, unless that happens, given our motivation to want to benefit by having our genome exposed to all research and all updates to that research and all the benefits of pharmacogenomics and so forth, what we really need is policy and implementation of that policy that detects and punishes any abuses and harm that is done by re-identification. So we may shift from a model of securitizing our information to a model of detection and punishing those who would abuse it. So that's a very big challenge, but I think that may be the enlightened path to get around this conundrum.
Boy, I love the way we have this total mind meld on that. I was just about to...
We need more dissent on the panel.
Yeah, right. Yeah, the whole notion, I think we need to move a regime a lot like insider trading. It's not, you know, whether you have the data or not, it's what you do with it.
Exactly.
You know?
Exactly.
Can I get you guys to talk a little bit to the entrepreneurs in the audience? So you're talking again about this way in which this could all go right. What is the entrepreneur's role in building that system, making these decentralized architectures valuable and stimulating this? And what are the big opportunities for entrepreneurs in this space? Either of you can go.
Well, I'll throw a couple things out. The first thing is familiarize yourself with data standards. If you're doing anything that handles healthcare data, make sure that what you're generating is maximally exploitable for the benefit of the people who purchase whatever it is that you're developing. Jordan's suggestion earlier, follow a doctor. There's a whole field called ethnography that illustrates the difference between what a doctor will tell you they do versus what you can watch them do. And trust me, you will see a very different story when you watch someone. One of the mantras that I give to everyone on my team is convert frustration to innovation. Watch when they get frustrated. There's your probe into an opportunity to innovate. Because if they're frustrated, that means that they can somehow, and somewhere in the past, they've imagined a better way to do it and they've just given up and they're frustrated. And then the last thing I'll mention is that anything you do, and today the world has changed very dramatically. So for 20 years, people have been using the term that Andy Groves used earlier, that this is unsustainable. The cost escalation curve is unsustainable. 20 years we've been saying that, and it keeps going up. Well, guess what? We're finally at a point where it really is truly unsustainable. It's damaging us in two ways. In the international marketplace, we're not globally competitive because of the share of products that's committed to healthcare here versus abroad, 18% versus on average less than half of that. And the other is we don't have enough military recruits who can meet basic physical requirements because of obesity to join the military. So it is, we are at a point of unsustainability. It's now, and so we need to do that. So when you think of putting a new product in the market, it of course is going to improve convenience and user satisfaction and healthcare outcomes, hopefully. But if it doesn't also lower costs, find another problem to solve, find another solution. If it doesn't lower costs, you're going nowhere. People are not going to say, oh, we're going to keep doing what we do and we're going to do what you're offering us. You must displace something that is currently more costly. There are tons of opportunities to disintermediate many of the players in healthcare who are not adding a whole lot of value but are contributing a lot of cost.
That was awesome. That deserves a little round of applause. Yeah. Thank you. Tim, you talked about a lot of specific stuff in the paper. Do you want to get?
Well, I actually want to pick up on something you said. In one of her talks recently, Jen said, correct me if I get this quote wrong, what would it be like if we felt about our government the way we feel about our iPhone? And I think in a similar way, there's an opportunity for healthcare, which, Jordan and Tom were talking about earlier. What if you felt about your healthcare the way you felt about your iPhone? What if, again, to take a quote from a Code for America fellow, what if interfaces to government substitute healthcare? What if interfaces to healthcare could be simple, beautiful, and easy to use? We're really at a point where there's this whole back end, but there's also a huge amount of opportunity for innovation on the front end. And I think, even though I totally agree with your comment about reducing the costs, I think there's a really interesting counterpoint, which is to say, how would you make something that's so good that people would actually be willing to pay for it? Would go out of their way. And in fact, if you look at the world of healthcare, there's a huge shadow market for healthcare things that are not part of this system that everybody hates and looks on with some kind of disdain. Where people are giving themselves all kinds of quack nostrums, multi-billion-dollar market in things that don't really work, but that have that feel-good feeling. So to me, taking out when I was hearing Jordan talking about sort of concierge medicine, I've been thinking a lot about that because we also, in addition to having this huge cost problem, we also have, a massive unemployment problem. And we have people getting older. We have demographics that are going to say we're going to be needing more health care. So how would you actually build a healthcare system where people had a great experience? And some of that might be more healthcare delivered by people who are not physicians in settings that are not hospitals, and more preventative care, more follow-up care, more interesting ways that people feel really cared for, and as a result use less of the really expensive parts of the system. So there's a lot of innovation out in that area as well.
And Tim and Jen and I were talking in our prep for this conference about how the third world has a lot of experimentation going on right now that may be immediately relevant to what we're doing here. And the reasons for that are twofold. One, they don't have the crushing inertia of the existing infrastructure. And two, they have no money. And so they're innovating in some very, very cool ways about how to intervene more at the community level than at the professional healthcare level. If you haven't seen The Weight of the Nation, the HBO series, how many people have seen The Weight of the Nation? Those of you that haven't, please watch it. You can watch it online. It talks about what are the major contributors to the decline in the health of our population, independent of our healthcare system, and methods to address that. The other thing I'd like to circle back to, if I could, is around trust. And so one of the things that I see happening, in addition to what Tim was saying about how we need to have non-classically clinically trained people helping advance the healthcare of our society and culture, one of the things that I see happening already is the notion of health coach avatars and aspirational avatars and information agent brokers. So this flood of information that's going to come from big data, and the earlier panel referred to this, is going to inundate and overwhelm not just the physicians, but the consumer as well.
Yeah.
We need to have intelligent brokers, and we need to have brokers that are interested in what you have as your personal objective. So you want better health at lower cost, and ultimately you want more happiness. There's this whole gap we didn't even get into, is the gap between health and happiness. And if you haven't read Harvard Business Review January, February issue this year, the entire issue is devoted to happiness and metrics for happiness and international metrics for happiness, which is phenomenal. So we're using healthcare as a proxy for happiness, but they're really two different things. And so as we go down that path, and as every one of us 5-10 years from now has 2 or 3 avatars that are helping us broker the interface between what we want and what the universe offers in terms of information, it's going to become the ultimate sales channel. That's where sales and marketing for every product under the sun is going to come. So what's going to happen is, rather than those being purchased by us, they're probably going to be offered by free by merchants as direct-to-consumer sales channels. So the thing I worry about, so Jen said, what's the dark side of all this big data? I think this is the biggest, darkest side of big data, is that these avatars are going to be free. They're going to know us. If you saw Face View that was released recently, and how your picture's taken when you walk in a store, and they offer you coupons discounted based upon your preferences as stated in Facebook. This kind of big brother aspect of sales and marketing is real, it's here, and it's going to advance, and it's going to be through the channel of healthcare, because we all want those avatars. And so to the extent that we use these avatars to help us guide our health and our choices, beware. Who owns that avatar, and what do they really want from you?
That's a really good point. If we're talking about avatars, and we'll eventually get back to robots, then I'm going to use that as a transition to ask Tim to draw this parallel between what's going on in healthcare right now and the maker movement, and what could healthcare learn from the makers?
Well, first of all, when you refer to the maker movement, how many people here have ever been to Maker Faire? So it's a DIY hardware. There's everything from manufacturing to sensors, and there's a lot of overlap. But to me, the biggest point about the maker movement and healthcare is simply that sense of permission to innovate. And sure, there are medical makers. I'm thinking of Jose Gomez-Marquez at MIT, who makes medical devices for the third world out of consumer toys. It's just fantastic, kind of very makerish stuff. But for me, the biggest thing is simply that permission that you see at the beginning of a new movement. When the early days of the web, we were all makers. We kind of we weren't just sort of putting up our Facebook page. We had to learn a bunch of skills and do new things. And the makers of today are out there with new hardware and new techniques. But before long, those things will become systematized. What I love about the maker spirit in healthcare is this notion that we can reinvent it. We don't have to wait for somebody in a big company. We don't have to wait for Congress. That we as individuals, as entrepreneurs, as anybody with a vision that it could be better, that we can and should take the future into our own hands.
And with that, I just want to give a shout out to Hallie Tecco for starting Rock Health. I think the power of bringing the entrepreneurs together to really see what's going on in the healthcare business and really disrupt it, I think, is so important. And I just love what she's doing here. I love that all of you are here.